So patients who are older certainly have more challenging circumstances in terms of deciding on choice of treatment. We have discussed that three-drug regimens have become the norm. The fact, though, however, is that some people we need to improvise treatments because they cannot tolerate three-drug regimens still. In that regard, we know that giving these patients sometimes just a two-drug regimen of ixazomib and dexamethasone may be sufficient to produce a response and maintain quality of life. In other cases, we sometimes use single agents like daratumumab as well. In this patient with a performance status of 2, the three-drug regimen seemed to be an appropriate initial choice. It would, I think, provide the right balance in terms of improving efficacy, depth of response, progression-free survival, and still maintaining quality of life. Ixazomib is a drug that adds little to the toxicity of lenalidomide and dexamethasone. It is a drug that has got certainly some potential to cause neuropathy, some potential to show up with rashes. Like any drug we use for myeloma, some element of fatigue is often reported. It doesn't add much to the hematological toxicity of lenalidomide and dexamethasone. So I think that in an older population, this three-drug regimen of ixazomib, lenalidomide, and dexamethasone is not much more toxic than what you would usually expect with lenalidomide and dexamethasone. The choice of treatment for patients with relapsed refractory disease is one that requires taking into account a number of factors, which include patient-related factors, disease-related factors, and things of the nature of the social environment of a patient. Patient-related factors include their, in addition to their age, their comorbidities, their performance status, their renal function. For disease-related factors, the aggressiveness of the disease, the cytogenetics of the tumor play a role in our decision-making. And then the very fact, does the patient have a caregiver? How far away does the patient live? What is the patient's own desire? Is he able to afford copays for oral medicines? These all factor into our choice of treatment. The patients who are being followed closely by doctors, especially when they're seeking a second-line option, are often picked up when the disease is just showing evidence of what we call a biochemical progression. They're often not symptomatic even, and in that scenario, it is often even debated whether changing treatment is even necessary. However, with the abundance of options that we have now, we certainly have probably started treating patients earlier than we would have in the past. The things that we often do at the time of first relapse in a patient who has otherwise a biochemical progression is to get a PET scan and a bone marrow biopsy often to see if we can get a better sense of the bulk of disease. In a patient who has biochemical progression and has a PET scan, I personally treat that patient as if he has true symptomatic progression with the evolution of new CRAB criteria that other audience is familiar with here in terms of its relationship to multiple myeloma. The patients who have got a slow progression of their disease, I'm often comfortable using a three-drug regimen like elotuzumab, Revlimid, and Decadron, or ixazomib, lenalidomide, and dexamethasone. And these regimens are usually well tolerated. They provide a good balance between toxicity and also their efficacy. Also, convenience favors oral regimens. The regimen of elotuzumab, lenalidomide, and dexamethasone, though a regimen that includes an IV drug, is usually well tolerated, and again, for patients with biochemical progression, offers a good choice. In patients who have more rapid progression of their disease, are more symptomatic, and otherwise healthy, I think that often we use 3-drug regimens like daratumumab with either lenalidomide or pomalidomide and dexamethasone, sometimes pairing the daratumumab with bortezomib and dexamethasone. The patients who have got daratumumab, or in some cases, even before daratumumab is used, the use of kyprolis-based 3-drug regimens is also an option. And in that regard, once again, kyprolis with lenalidomide, dexamethasone, pomalidomide and dexamethasone, or Cytoxan and dexamethasone for that matter, are popular regimens.